Good morning, everybody. We are going to get started. We feel like we've got sort of a critical mass of people who have arrived, so we are going to get started. We want to be obviously sensitive to your time and considerate of your time, and we've got a lot to do today. I am Dina Diorio. I am the Mecklenburg County Manager, and I want to welcome you to this community and stakeholder conversation about opioids in our community and opportunities for us to use the opioid settlement dollars that we're receiving as part of those major settlements that have just been resolved. And so just in terms of what we're going to do today, we have a few objectives. One is we really want to have a mutual understanding amongst this group about kind of where we are and sort of level set everybody and what the status of everything that's going on in this community. We want to provide information to you about some certain topics, and we'll go through those. And then, of course, the most critical piece of this is to get your input. We've got opportunities to do a little breakout work for you to give us your ideas and things that you think are important. And so we really look forward to that, and that'll be the basis for how we move forward. So this morning we are going to do a few things. We're going to get some context from Dr. Travis Hales, the Associate Professor from UNC Charlotte School of Social Work. We will be getting an overview of our situation here in Mecklenburg County from Lauren Kestner, who is the Associate Director of Queen City Harm Reduction. I will do a very brief presentation on the opioid settlement and the opportunities that we have. We will get a perspective of lived experience from a local attorney, Abby Shute. We'll break for lunch, and then we'll do the breakout work, and then we'll wrap up. I did want to just take a minute to recognize the elected officials that we have in the room today. We have several county commissioners, including Susan Rodriguez-McDowell. Commissioner Lauren Meyer is here. Commissioner Lee Altman is here. Commissioner Cotham has signed up, but I don't think she's here yet. We have our chairperson, Commissioner George Dunlap is here, and Commissioner Wilhelmina Rembert has also registered. We know she'll be here as well, and I also wanted to recognize Melinda Bales, who is our esteemed mayor from Huntersville, so I want to thank them all for being here. The person who's really going to lead the day is going to be Megan Palmer. Megan Palmer is the CEO and owner of Megan Palmer Consulting. She does a lot of facilitation work for the county, was a former county employee for many years, and so I'm going to turn the podium over to her to get us started. So again, thank you for being here, and I'm looking forward to a really great day.
Good morning, everyone. Thank you for being here, being on time, getting through security, going through registration, and all of that good stuff. We really appreciate your volunteering to participate because this is such a big opportunity for the community to give input on the opioid settlement and opportunities that Dina's going to review in just a little bit. A couple of housekeeping. If you aren't familiar with this building, if you leave these doors and go straight to the left are restrooms and also a water refiller. If you would like to fill up your water, we're trying to save the community or the environment. And as you can see from the agenda, you've got some things at your tables. So you have the agenda and it is packed. This morning, you are going to be hearing from the experts and people with a lot of experience and knowledge about the opioid crisis. And I will introduce them in just a minute. You also have this handout. It's in color, and it has 11 strategies that you will be discussing after lunch. If you have trouble reading this, we have a larger, I don't know if I brought it up, and easier to read. The table hosts, which I'll discuss in a minute, have just a limited number of these. We didn't want to kill too many trees, and this is on the landing page of mecnc.gov. So if you need that, you can share at your table, or if you really want your own copy, we can provide that for you as well. You also have a big printout of the strategies we're going to be discussing. It's in English on one side and Spanish on the other. Okay. So we good? Okay. We're going to break for lunch at 12:15. We're going to do our best to stick to this agenda and get you out of here because we know that you're busy and there's lots going on that you've got to pick up kids or get back to your work. So we're going to break at 2. But lunch will be at 12:15. We have boxed lunches that will be lined up outside on the hall. There's going to be 2 lines, so you could go on either side. And there's a few vegetarian options as well. We ask that we only have 20 minutes. You pick up your lunch. You can eat it at your table for the afternoon breakout groups and go to the bathroom. But we will start back promptly at 12:35 because that's when you're going to roll up your sleeves and do the real work. Okay? All right. So with that, I would like to introduce our first speaker, Dr. Travis Hales. He is an assistant professor and MSW program director at the University of North Carolina, Charlotte School of Social Work. Dr. Hales serves as principal investigator for the studies entitled Examination of Opioid and Drug-Related Deaths on Addiction, Provider Well-Being and Performance, and Evaluation of the Child Development Community Policing Program. He also serves as co-principal investigator of the Mecklenburg Opioid Systemic Response Plan and co-investigator of the evaluation of the Supportive Housing Innovative Project, also known as SHIP. His areas of interest involve developing an evidence base for trauma-informed organizations and examining the psychological impact of clinical social work, with an emphasis on risk and protective factors for experiencing burnout, fatigue, and developing therapeutic alliance. Dr. Hale's teaching interest involves social work practice and program evaluation, research, and organizational cultural structure and climate. So with that, let's welcome Dr. Hales.
Hello. Good morning, everybody. Yeah, so today I'm going to be talking about the context of the opioid epidemic. And we're going to start out by talking about some national trends and statistics, and then talk about statistics and trends that we're seeing here in Mecklenburg County. And lastly, a couple of risk factors for experiencing opioid use disorder and substance use disorder. Okay, I'm going to do a mix of reading because some of these stats are, there's a lot of stats, so I hope people like stats. From 2000 to 2020, there's been a steady increase in the total number of overdose deaths in the U.S. So you can see from this figure here, these represent the total number of individuals that have died from an overdose in the United States from 1999 to 2020. Okay, so in the previous 7 years, we have seen an exponential increase. And this is largely due to a number of factors, the primary being really the introduction of a significant number of illicit opioids containing fentanyl. Right, so in 2020, nearly 92,000 persons in the U.S. died from a drug-involved overdose. This number nearly doubled from 2015. The spike from this is largely contributed to fentanyl. And really there has been a reemergence of trafficking, distribution, and abuse of illicitly produced fentanyl and fentanyl analogs in the United States. We all know fentanyl is a synthetic opioid that is 50 times stronger than heroin and 100 times stronger than morphine, and is commonly laced in opioids as well as stimulants such as cocaine, methamphetamine, and to a much, I can't even say this. People, a lot of times, there are certain case studies that show that it's been in marijuana and things of that nature, but those are very trace amounts. Primarily opioids and stimulants like methamphetamine, cocaine. Okay, now opioids specifically, these are all drug overdose deaths. But of the 92,000 deaths in 2020, 68,000 were directly attributable to opioid-involved overdoses. So that's approximately 75% of the total deaths in 2020. This next diagram here breaks these data down by the different types of substances. So that very significant spike you see skyrocketing, that's opioids, including fentanyl. A couple other key pieces here are that we are seeing spikes in the number of overdose deaths, that are a result of cocaine and methamphetamine. But one of the major drivers in the opioid pandemic has been prescription opioids. You can see that, I believe it's the orange trend line here, and it's the one that just keeps gradually increasing. And it's through prescription opioids that most individuals are initially introduced to recreational opioid use. Okay. Now, these are the counts that are specific in Mecklenburg County. The overdose deaths that we have seen that have been reported by the medical examiner's office over the past approximately 10 years. And a couple important things to note here is that relative to the previous slide, we see the spike here similar with fentanyl, but over the past 3 years, it hasn't been as dramatic in Mecklenburg County as it has in the US. And this is definitely attributable to a lot of the work Mecklenburg County's done, especially around harm reduction and limiting the supply of prescription opioids available in the community. So as you can see, the spike in the national data from fentanyl is very significant, increasing exponentially, nearly 10 times as much from 2013 to 2020. But in Mecklenburg County, we have curtailed it, which is great. Now we see that the number of overdose deaths from cocaine has continued to rise in Mecklenburg County. That follows the similar trends that we've seen on a national level. And we have actually seen, contrary to the national level, a decrease in the number of overdose deaths involving prescription opioids. Okay. Right, and I did find this. A lot of the data that I get does come from like National Institute on Drug Abuse for the national statistics. But here in North Carolina, we do have the opioid dashboard that's available to us all. There are certainly limitations with these data, but they can provide, some of the indicators are very concrete, they're valid, reliable. So one of the main reasons why we have seen a dip in the number of opioid directly involved deaths in Mecklenburg County has been a significant decrease in the number of prescription pills prescribed. So in 2016, there were a total of 185,000 opioid pills prescribed in Mecklenburg County. But in 2020, this number reduced by approximately 35% to 118,000. So the medical community has definitely collaborated and worked together in Charlotte to try and limit the number of prescription opioids that are made available to the public through prescribing. This diagram here compares the number of overdose deaths from opioids in North Carolina relative to Mecklenburg County. So you can see these rates are all per capita. So how many individuals in Mecklenburg County and in North Carolina per 100,000. There were a total of 224 overdose deaths in Mecklenburg County in the year 2021. And per capita, it is lower than North Carolina as a whole. Okay, so this is a good statistic. And again, one of the reasons why we have seen this decrease is largely in part to a number of coordinated efforts at the county, as well as a lot of the harm reduction agencies that we'll be hearing about momentarily here. Now this is basically the exact same diagram, but put in a table format. So these are the actual counts of the total number of overdoses in Mecklenburg County compared to North Carolina over the previous 11 years. And here, seeing the actual statistics and counts, we can see that while the past couple years we have mitigated that exponential increase, but the numbers have still risen at a pretty significant level from 2010 to 2015 and from 2015 to 2020. So clearly here we can see in 2010 there were 66 overdose deaths in Mecklenburg County. In 2020, there were 236. So we are definitely seeing a pretty significant increase, maybe just not at quite the same exponential level that we're seeing across the US. Now, these are some of the key indicators that, like as a researcher, I look at for trying to understand the impact of the opioid pandemic, such as deaths. But there are also other important indicators. Some of them definitely include things like reversals, but also emergency department utilization. So the opioid dashboard in North Carolina, it has been producing the emergency department utilization for an overdose for a number of years. You can see the diagram's a little abbreviated, really starting in 2014. And here we can see that the ED utilization in Mecklenburg County pretty much follows the exact same trends that we see in North Carolina. Okay, now as I noted, there are definite like issues with the data here and reporting quality and things of that nature. Pretty much there was a mandate in 2005 that required all hospitals with emergency rooms to report their data on a daily basis in North Carolina. But we know from word of mouth that not all institutions are reporting these data at least as frequently as they should be. So one thing I'm not sure if I mentioned, but I am the data work group chair in the Mecklenburg County Substance Use Disorder Task Force. And this data specifically are some of the things that we constantly report out on during our regular task force meetings. These data right here are the emergency department utilization for individuals that have an overdose. And we use these data to stay a little more up to date in the previous 12 months to see how the trends are flowing. And one thing I didn't point out yet, but during the pandemic, we definitely saw a very significant increase in the number of overdoses resulting in ED utilization, and overdoses resulting in death. Okay, and there are a number of different reasons why people think that might be the case. A primary one being social isolation and using opiates to treat different mental and behavioral health disorders. But here you can see, you kind of start to get a sense of when somebody does have an overdose, a lot of times, someone will get called, someone will put in a 911 call, they'll come in, they'll do a reversal, administer naloxone, and then an individual has to consent to going to the emergency department. So these definitely aren't an indication of the total number of overdoses that happen in Mecklenburg County. We have been working with CMPD to try and get some of the data around 911 calls, like how many of those come in on a quarterly basis, yearly basis, which helps kind of paint the picture a little bit clearer. But these are just emergency department utilization of individuals that have been administered naloxone or have a different type of overdose that come in. These are specific to opioids. And the common opioids that we see of persons utilizing the ED are unspecified opiates, followed by commonly prescribed opiates, followed by fentanyl. Okay, so those are the three main opiates that come up when persons come in and utilize the emergency department. Now, these data come from the Injury and Violence Prevention Services as part of Department of Health and Human Services here in North Carolina. And they break these data down by age and ethnicity, so we can start to get a sense of essentially amongst the ED users, who is this mostly affecting? And are there potential like higher risk groups? So we definitely can see from these data that people aged 25 to 34 and 35 to 44 are the most at risk for experiencing an overdose and utilizing the emergency department, being treated there. We also see that persons identified as black or white also compose the majority of people impacted and being seen and treated by the emergency department. But again, there are pretty significant issues with this data quality. It's one of the reasons at the task force we've been trying to develop partnerships with institutions and agencies in the community to get very representative data. So here you can see that in the total population in Mecklenburg County, under the Hispanic column, it's basically indicating that there are no individuals in Mecklenburg County that identify as Hispanic. Okay, so these data aren't necessarily the best, but they are indicators, they're general, we try to use them to inform what it is that we do. Okay, now this is where it gets super nerdy and researchy, if it hasn't already gone there. But there are a number of different types of theoretical models that are based on evidence that try and explain, let me double check the time. I'm doing good, okay. So there are a number of different theoretical and causal models that try and explain how the epidemic has really become such a significant problem here in the United States. This is one such model. It is based on evidence and systematic reviews, and it gives a really good narrative around essentially what started the whole epidemic was the overprescription of opioids in pharmacy mills, to where prescription opioids were just getting funneled into the streets. This is what pretty much like the majority of adolescents who are introduced to substance use, this is how they initiate recreational opioid use. Now, this is called, in a lot of the research terms, free use. The supply, however, especially since a lot of the efforts that have gone on in the country through law enforcement and limiting the number of prescriptions, the supply of prescription opioids in the community is getting smaller. It's a really good thing because that's going to stop that initiation. However, for the people who are relying on free or readily available prescription opioids, if they have developed an opioid use disorder, they're going to pivot to paying for opioids. And they're doing that through illicit substances that they're finding on the streets, which we know are contained in fentanyl. So over time, limiting the number of prescription opioids that are available will hopefully ultimately have an effect in lowering the total number of individuals that develop OUD. However, they are pivoting individuals using them recreationally to developing them illicitly on the street, to getting them, street drugs that contain fentanyl. So one thing that I really like about a lot of these theoretical models are that they also point to areas of intervention. So one area of intervention is if we want to stop the initiation, then we stop the overflow of prescription opioids. The other is clearly if somebody has already developed an opioid use disorder, there are a number of harm reductive strategies that you can pinpoint on here that help limit the mitigating effects of opioid use disorder and try and prevent the deaths from occurring at the rates that they've been occurring to. Things like syringe exchange programs, making sure that naloxone is readily accessible, that people in the community are trained to detect when someone's experiencing an overdose and trained on how to administer naloxone. But there are a number of intervention strategies that can come from these path models. And lastly, this is an ecological map that talks about risk factors. So definitely for substance use, there are a number of risk factors for developing SUD in general and OUD specifically. They definitely occur at the individual, interpersonal, and community and societal levels. At the individual level, a lot of it does come down to genetics. So it's not just like a genetic component, but it's also learned behaviors from your parents and your parents' parents, et cetera. So there's definitely a generational component to opioid use disorder and substance use disorder. And I'll say this too, trauma is a significant impact and a significant motivator for individuals that develop SUD, especially childhood trauma and childhood adversity. When I first wanted to become a social worker, I wanted to become an addiction therapist. So I went into my MSW programming, and when I was there, I read something by Harrison Fallett. They're sort of like the originators of trauma-informed care. They're researchers. And they did a study on women in inpatient psychiatric and substance use facilities and found that 90% of the adult women in inpatient substance use had a history of childhood sex abuse. 90%. That is basically a perfect correlation. So there are a lot of risk factors to developing substance use disorders. We know what a lot of them are. And throughout the day today, we are going to talk about the different strategies at the different levels to try and address and mitigate the negative effects that the epidemic has had across the country and here in Mecklenburg specifically. So that's it. Thank you, everybody.
If we have time at the end of the presentations this morning, we'll open the floor up for questions, but in the interest of sticking to the agenda, we're going to move on. So if you do have any questions, just make note of them, and we'll try to circle back around, okay? So thank you, Dr. Hales. Our next presenter is Lauren Kessner to provide an overview of Mecklenburg County's situation with regard to the opioid crisis. Lauren is the Associate Director of Harm Reduction at Center for Prevention Services, also known as CPS, not to get confused with child welfare, located in Charlotte, North Carolina. At this agency, she oversees Queen City harm reduction and manages special projects that bridge harm reduction, prevention, public health, and the arts to improve drug user health. She is a certified prevention specialist and joined CPS in 2017, where she worked with youth to offer evidence-based, resilience-focused workshops. During this time, she developed the Harm Reduction Department, which, to date, directly benefits approximately 8,000 adults impacted by substance use and comorbid conditions such as HIV, hepatitis C, and mental health. Lauren is especially passionate about addressing the conditions that perpetuate substance use among marginalized populations. So Lauren,
Good morning, everyone. Thank you for the introduction, and thank you, Travis, for such a good presentation. I will start by telling you all I am very nervous. I do not enjoy being up doing these things, and oh, I can see my slides there. That's great. So, as Megan kindly introduced me, I'm Lauren Kessner. I work at Center for Prevention Services, and I oversee Queen City Harm Reduction. We are currently the only syringe service program in Charlotte, Mecklenburg County, and we work with an enormous amount of partners throughout the state and awesome local resources here. So this presentation was a bit challenging for me to put together because harm reduction is really dynamic. And so I really thought I'd start by painting a picture. I feel like this forum really needs to understand a little bit of historical context, but please note that there's no way we can unpack everything that we would need to in 2 hours, let alone 20 minutes. So in 1971, when Nixon declared the drug war, this was not the beginning of a war on people. This began centuries before and has just destroyed neighborhoods, targeted minority communities, youth, and families. It spent billions to protect and prevent, and has instead killed, oppressed, redlined, and perpetuated fear and stigma in and around cultures and habits that are not necessarily bad or immoral. They are often misunderstood. This is a great chart that shows in 1989 when pain was added as a fifth vital sign. This is very close to when overdoses skyrocketed and prescriptions skyrocketed. And this is when it surpassed auto vehicle accidents and fatalities. And you see that drug misuse and overdose caused more death. And when Big Pharma kicked into high gear with OxyContin and other opioid prescriptions that fueled overdose deaths starting in the early 1990s, it creeped into the homes and neighborhoods of some of our more privileged community members. As white families and young people experienced an overdose of a loved one, an opioid crisis was born, and Big Pharma was to blame. At the same time, a drug war continued to rage on. And it did begin to get attention from really young advocates, and the history of racist and classist treatment was highlighted in models that showed a lack of retention, a lot of prohibitive requirements, and recidivism was very much alive. This last image is to show you that we are long past preventing a lot. We can delay, we can curb, and we can address, but we are living in an age of synthetic analogs that we cannot keep up with. Fentanyl is here to stay, heroin doesn't really exist anymore, and we are dealing with contaminants such as xylazine and nitazines and a whole bunch of others that I can't pronounce quite honestly. So let's not Band-Aid another solution here for our community. You know, this is really an opportunity for us to come together and really hold the dam. This next slide is to show 1 year's estimated total lifetime costs, and there's a few other pieces. I don't really think I need to speak to the numbers. I think they speak for themselves. This does not include treatment or testing for HIV or hepatitis C. It's also not including with some of the comorbid conditions, which I just mentioned. One important thing that it doesn't mention is funeral costs and lives lost. You know, a lot of the families that have to undergo that tragedy. And then I also put on the screen the cost of endocarditis. We often don't recognize the bacterial infections that are associated with drug use, whether that's through injection, smoking, snorting, what have you. There's a lot of different consumption methods. So endocarditis is a very concerning infection that causes a lot of fatalities among drug users, and these are the costs associated with that. And so I really love this slide. This is one of my favorite quotes. And we are in a moment of time where we have learned, we need to unlearn, and we need to relearn. And the illiterate of the 21st century will not be those who cannot learn or who cannot read or write, but those who cannot learn, unlearn, and relearn. And for all the things that we don't understand, drug use, sexual behaviors and identities, things that ignite emotions like fear and anxiety, we need to have a lot more willingness to get uncomfortable, to have really tough conversations, and forge really progressive pathways that support people socially and through all types of healthcare models. This is a slide that represents one of a few great pieces of evidence-based strategies for preventing opioid overdose. There are 10 awesome approaches listed. There are 5 highlighted: targeted naloxone distribution, medicated assisted therapy, 911 and Good Samaritan laws, MAT in criminal justice settings, and syringe service programs. I am here today to talk specifically about syringe service programs. Queen City Harm Reduction, again, is a program of Center for Prevention Services. We work with directly impacted people who use drugs, people who are legally involved, people who do sex work, people who are members of the LGBTQIA+ community, people from all walks of life. The North Carolina Syringe Access Law was put into effect in 2016. This law protects program members and people who use drugs who are coming to and receiving supplies from a syringe service program and returning supplies to a syringe service program. I know that can be a little confusing, but we do a lot of biohazard waste. So when people are finished using their syringes, they safely return them to our exchange, which is in a drop-in center. And we have a fabulous manufacturer come and pick them up. This is a slide that defines recovery, which was actually put out by SAMHSA, our federal leaders with substance use and mental health. And they define recovery as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And harm reduction works on a continuum of excess, moderation, and abstinence. And we also work to dive into the roots of what's causing the conditions. And so we do understand that for every step forward, there are often steps backwards, and that this is a continuum that evolves and is pretty fluid. Any steps toward decreased use is a step in the right direction. We work off a series of principles and strategies that promote health and wellness, a spectrum of strategies that encompass managed use, MAT, and abstinence that help meet others where they are at and offer needs-based care. It's founded on dignity, respect, and compassion for all life, minimizes the harms associated with drug use and chaotic living, and prevents the spread of infectious disease, and again, has a priority focus on vulnerable populations. We are a needs-based program. We lean very heavily into Maslow's hierarchy, and I put a giant red arrow to show you that we place a lot of emphasis on physiological needs: food, clothing, housing, safe supplies, sterile supplies. We work to mend the gaps that are often missing people and their needs. And as people have more needs met, starting on a physiological level, they feel safer, they feel more supported, and they have an arsenal of community members and other support systems that can gradually help them see safety, love and belonging, building their self-esteem, and coming to a place of self-actualization where I, Lauren Kastner, am empowered to go and take on the world. Not really. This is a little bit of our data. We actually collect a lot of data. It drives our programs. And I can't read everything from where I am standing, and I hope that you can. Total syringes that go out, total syringes that are returned, total naloxone kits that are distributed. I want to put emphasis on the fact that that's 2 vials in each naloxone kit. So you're going to want to double that amount. We do filter through every year. So this is our last fiscal year, which was June 2021 through July. Did I do that wrong? I may have done that. No, I did that right. June 2021 to July 2022. Thank goodness. And how many people we came into contact with directly, and then how many people we reached on a secondary distribution level. And so to define that really quickly, those are our peer distributors. So we have volunteers and program members who work alongside us and go out into the community into hard-to-reach areas and provide supplies and education to other people who otherwise would not have access to these programs. And so when I was mostly making sure that I wasn't going to duplicate slides with Travis and any data points, I noticed on the dashboard for the Department of Health and Human Services here in North Carolina, when it comes to community-based distribution, Mecklenburg County and the city of Charlotte have been really proactive. There's a lot of organizations, there's a lot of sober livings that we know and that we don't know that are providing naloxone to individuals. And so I thought it was really interesting that they had captured 270 lives saved that was reported. And I would have to double check with our partners at the state, but that could be emergency shelters reporting lives saved. That could be family members reporting lives saved. On our data, people who use drugs who are also first responders and saving the lives of loved ones reported 435. So collectively as a village, we've saved 705 lives. And that's pretty cool. Targeted naloxone distribution is key. You cannot administer naloxone to yourself, someone else. You must administer naloxone during an overdose. The most likely bystander to an opioid overdose is someone else who uses drugs. Studies indicate that 80 to 90% of all life-saving opioid overdose reversals with naloxone are carried out by a community member, somebody who uses drugs. Secondary distribution I spoke to a little bit already, but again, we train, we arm, we provide education and resources to a slew of other peers in 4 counties, and they go out and do really awesome work. SSPs do it all. We try. We don't really, but we work with awesome partners, so we are able to bridge a lot of needs, and we are able to do a lot of linkage. Studies have found that people who use a syringe service program are many times more likely to enter treatment than those who do not. Syringe service programs are particularly good at attracting recently incarcerated individuals, ensuring they continue to have access to naloxone, MOUD, which is medicated assisted therapy for opioid use disorder, HIV care, and other essential services. Overdose, disease, and injury prevention efforts of SSPs are greatly reduced, I can't read, I'm sorry, by programs that require I can't read this right, but basically what it's saying is we don't do 1-for-1. You do not need to give anything to get supplies, so it's not best practice, and I apologize that my eyes aren't working very well. SSPs are heavily trafficked pathways to care. Participants are 1.4 to 3.2 times more likely to enter detox compared to those who do not. They are about 5 times more likely to enter treatment and about 3.5 times more likely to cease substance use altogether compared to those who don't. And what I also want to highlight here with this bullet point is when it comes to growing out of use, what I find really interesting is those who are impacted with substance use disorder and have comorbid mental health conditions, the male and female brain don't stop fully developing until 20s, 30s. For women, it's about 27. For men, it's about 32. And when you're impacted and your brain development is stunted, I find it interesting that most people are able to grow out of substance use. And then there are, it's actually a small pocket of people who are continued to be, that remain impacted with a disorder. And if you have any questions about that, I'm happy to elaborate later on. And we operate out of Drug User Health Hub. So we have a wellness center, which operates as a syringe service program, and a training center, and a testing center. And again, we don't do everything, but we do work with partners and providers who come to our site, or we link out to other sites. And so as you can see, people are really getting a nice full circle of care when used effectively, and when people feel safe coming to sites. We continue to do other engagement and work with people who use drugs throughout the community, and we work hard to engage the community at large to be a part of a lot of this work. We do naloxone kit-making events. We do the secondary peer distribution. We join health fairs and community events, holistic engagements, which is a lot of art workshops. Photo Voice is a project that we recently did. We also just launched a community garden. I am an artist by trade, so I just have a lot of heart for it, and I'm very sensory, and I am a person with lived experience, and it was something that saved my life, so it's something that I implement into this program consistently, and the Arts and Science Council have been wonderful allies. We do telehealth. We've done projects with Duke. We're working on another one with Gilead now, so lots of stuff happening there. And then, I've listed out some of the education and trainings that we offer. And it is said, and I'm going to need to read it here, that consistent connection is the enemy of substance misuse. By connecting people to resources, they are guided towards options that help individuals make educated and informed decisions that enable healthy living. Enable is not just a bad word. It is a very positive and very empowering word. There are a lot of other harm reduction strategies. There are a lot of ways to implement this philosophy into the work so many of you all do. We do drug checking. We encourage drug checking. And our partners at UNC Chapel Hill launched this program about a year ago. It's been a great way for program members to safely check their supply to see what adulterants might be in it. We often find that there are adulterants in it, and so this informs the user on whether or not they should continue to consume, or maybe consume a slightly lower dose, or maybe not use it at all. Medicated assisted therapies in justice-involved settings and upon release is so critical. Most incarcerated people have a substance use disorder. 58% of people in state prisons and 63% in local jails. And a great study, opioid overdose mortality among former North Carolinians that were inmates from 2000 to 2015, so this was over a 15-year period. The study of roughly 230,000 formerly incarcerated people released from NC prisons compared to the general population, formerly incarcerated North Carolinians, they were 8.3 times more likely to overdose in the first year. They were 40 times more likely to overdose in the first 2 weeks. They are 74 times more likely to overdose on heroin in the first 2 weeks after release. I also want to note that the suicide rate among those reentering into the community is also upwards around 70%. We need to do a lot more with transitional care. And I highlight some of that here briefly. So, oh gosh, I wish I could just turn this microphone around. So another great resource, it's the same resource, sorry, but on the dashboard you can filter. So you can see unemployment stats, you can see housing stats, you can see a whole bunch of stuff. And so this first slide shows unemployed individuals. And, we see a great steady decline. COVID hits, everywhere spikes, state and local to Mecklenburg County. The orange is local to Mecklenburg County. And now we've leveled off again. At the same time, our legally involved civic systems were working with justice folks and helping them re-enter into the community. So we see a really nice steady decline, which is really positive. But justice-involved people, specifically people who use drugs, are barred from social assistance and healthcare support. And so we see a horrible spike in emergency shelter needs and assistance for housing and calls to NC 211. And as the director of this program, I myself have never been more inundated with linkage and housing needs. And we were very fortunate to receive an award to support voucher and utility assistance, but quite honestly, it's not enough. So more housing, more comprehensive treatment or linkage so that people can effectively access treatment. And so as I close here, I just bring this slide back to everybody's attention to a very uncomfortable but very important process that will help unite us, help cultivate health and resilient communities. Here are your strategies, folks. And remember, harm reduction is really fluid. I like to think of it as the rings that unite the planets of the solar system, if you'll bear with my visual for a minute. We work throughout the spectrum and the healthcare continuum. It's not meant to really be one facet. It's meant to evolve through all. And if we can have some solidarity, which I really do feel like Mecklenburg County and the city of Charlotte is moving towards, there's a lot of lives to be saved. I appreciate your time.
Thank you, Lauren. Certainly some staggering statistics up there for you to consider along with Dr. Hale's presentation. Again, lots of information. If we do have time, we'll open it up for questions at the end. But we're going to hear from our county manager again, Dina Diorio, to review with you more information about the opioid settlement and opportunities, which you will be discussing later this afternoon.
Thank you, Megan, and thank you, Travis and Lauren, for those really, I think, really great presentations. So I'm just going to kind of walk you through kind of how we got where we are today, and I think a couple of the speakers have already kind of provided some information about kind of how the opioid crisis became to be and how we got where we are, but I want to go in a little bit more detail about that. The opioid crisis started in the early 1990s when the medical community was really assured by manufacturers that opioids were safe for pain management in the community. And we had instances where some of the research was really misused and misinterpreted. So an example was that there was an article in the New England Journal of Medicine that cited a study that concluded there was no danger of addiction when used in a controlled institutional setting with elderly patients. And so that data was totally misinterpreted. And as a result of that, that is one example of how opioids became into our community, in all communities, in a very large way. And so at that point, marketing of opioids to the medical community was exacerbated, and this resulted in a lot of pill mills and a lot of the other things that we've been hearing about over time. In addition to that, federal law requires that opioids be delivered to retailers not by manufacturers but by distributors. And the distributors are required to keep track of what's happening with those pills and report any abuse that they might see. And one of the things that we found in this crisis is that the reporting was not taking place, and what resulted in that is we had these pill mills and doctors that were overprescribing opioids. And we had situations, I think West Virginia is a good example of this, we had towns in West Virginia that had populations of hundreds, but that there were prescriptions of the hundreds of thousands that were being filled and distributed across communities in the country. And of course, the impact of that crisis has been felt across all of our communities in all different ways. So we see it in our healthcare system, in mental health, social services, law enforcement, jails, and other public agencies. And in early 2016, entities really began to take a look at this issue and really started to determine that they wanted to pursue litigation against manufacturers, distributors, and retailers. And by 2017, these national litigation firms started to take up the cause and really started to develop multiple plaintiff lawsuits. In addition to that, there was a lot of states' attorney general that were also getting involved in this litigation. And of course, Josh Stein, the Attorney General of North Carolina, was one of those that was interested in bringing litigation against these individuals or these entities. So ultimately, there were over 3,000 lawsuits that were filed across the country. And in North Carolina, we had 76 counties and 8 municipalities that filed lawsuits. And in 2017, we had what was called the MDL, or the Multi-District Litigation, was formed in the U.S. District Court in Cleveland, Ohio. And really what they did there is they said, we want to take all these lawsuits, we want to consolidate them, and we really want to try to go for a global settlement. So these were not class action suits, these were individual lawsuits that were being brought against distributors, manufacturers, and retailers. And then in 2018, the North Carolina Association of County Commissioners, which has really been a partner for us in this effort, brought together all of the county attorneys across the state to meet with these law firms, these national law firms, to really try to understand what we should do as a state and what individual counties should be doing to address this issue of litigation in their respective communities. In addition to that, the North Carolina Association created what was called the 555 Committee. And the 555 Committee included 5 county commissioners, 5 county attorneys, and 5 county managers. And I was fortunate enough and very honored, quite frankly, to be part of that committee. And that committee was really charged to work with the Attorney General's office to determine what was the best allocation methodology that we could negotiate, so when the settlements came forward, that we knew exactly how our proceeds were going to be allocated amongst the various entities. And this was really important, because if we didn't reach an agreement with the Attorney General, we would have been placed into a default allocation methodology, which would not have been as favorable as what we were able to negotiate. And so we did come up with an allocation methodology. We entered into a memorandum of agreement, and this will drive how all proceeds will be distributed across this community, from the settlements that we already know about and any future settlements, because we know there are future settlements that are yet to resolve themselves. But what you see here is the allocation methodology for North Carolina, and I think this is really important because 85% of these dollars go directly to local governments and 15% go to the state. This is by far the most favorable methodology that was been able to negotiate in the entire country. And so we had a very, very fortunate to be able to work with a group of people at the Attorney General's office that understood that counties and local governments are the boots on the ground, and that we were the ones that would be best positioned to deploy these dollars and make sure they got where they needed to go. So we are very, very grateful for that. So as you probably all know, in February of this year, there were 4 companies that agreed to settle for a $26 billion settlement. That was in February 2022. North Carolina will receive $758 million as part of that settlement. Mecklenburg County will receive $32.3 million. City of Charlotte will receive $8 million. We've already received $3.9 million, so we have money that we've received that we're ready to deploy. And I think if the city is on the same schedule as the county was, they should have received about $988,000 so far of their settlement. You probably know the funds will be distributed over an 18-year period, and they will be front-loaded, so we'll get more of the money in the shorter years, the more current years, so it allows us to deploy more dollars more quickly. And I want you to know that this effort that we're doing today is a collaboration between the City of Charlotte and the towns of Davidson, Cornelius, Huntersville, Matthews, Mint Hill, and Pineville, because we want to make sure that we have a county-wide approach to this and that everybody has access to the resources. And so I know that there's some of my colleagues here from some of the towns as well, and the City of Charlotte as well, so thank you for being here today. And the MOA is very specific about the evidence-based high-impact strategies that we are allowed to use as part of this settlement. And you can see they go from prevention, treatment, and recovery. And these are the high-impact strategies that we want to deploy as part of our distribution or use of our proceeds. And these are the things that we'll be talking about today, and we'll be getting input from you on how you think these can be deployed, what do you think is most important, and then at the conclusion of today, we'll be launching a survey that will be deployed to this group only, where we're going to ask you to prioritize your top 5 strategies, and then we will use those to put together our funding plan. But I will go through sort of more of the next steps later, but this is sort of the area that we're going to focus on today. So that's really all I needed to tell you so far, and with that, I will turn it back over to Megan. So thank you.
Yeah, so as Dina referenced, you were going to have some big decisions to make this afternoon, and we will go more into how we're going to ask you to prioritize those strategies, and that will be combined with other data input that we have from other sources. We have a few minutes left before we break for lunch, and I would like to open it up for questions for any of the presenters, the panel. If you have any questions, it would be now would be a great opportunity. Mr. Dunlap.
Yes, there was a presentation, I think, by Lauren, harm reduction.
Lauren Kessner. Yes.
She made the comment that they were doing something, but they weren't using best practices. And I want to understand why they were not, why what they were doing was different or better.
Okay. Do y'all have a handheld microphone that we can use? Okay. So the question was that Lauren, if you couldn't hear in the back, she referenced where best practices were not being utilized, and so the question was a follow-up on that.
I can't. Oh, there we go. Hi. To answer your question, so there are areas of the nation where syringe service programs practice what's called a one-for-one. This was something that spawned with the HIV epidemic back in the early 80s. So in order to receive a sterile syringe or any supplies, you had to return a used syringe, and that is not best practice. So the state of North Carolina and many others that are now legal states for syringe service programs, because bear in mind, even in 2022, we still have a lot of illegal territories, we do not practice a one-for-one. You can go to any syringe service program in any area of North Carolina and receive supplies without having to exchange anything. In fact, I'll also go on to say that we used to be called Queen City Needle Exchange, and we dropped the exchange because we wanted people to understand that there was nothing that they had to give to receive, because there was a lot of confusion there.
Thank you. Other questions? Okay, I'm going to give it the microphone so that everyone can hear you.
I heard you say that heroin doesn't exist anymore. What does that mean?
So it really, it does. If you're farming it somewhere, let us know. It just doesn't. So what happens with prohibition is supplies no longer become safe, and heroin, especially, and it happened well before COVID, so I really want to be careful here, and if you guys want me to follow up offline, I'm happy to. But it got very costly. So the street supply was no longer costly, it was also unsafe. And so fentanyl, which was a formerly prescribed medication, was getting produced a lot in different laboratories. So it is a man-made synthetic drug that the cartel took into, and originally put it in with the heroin supply to break it up. But because it was so much cheaper and because it was so much more potent, not necessarily more deadly, more potent, and we weren't armed with the education, we saw people get a rush and a high that they didn't experience with heroin, and fentanyl became higher in demand. And so you just do not find actual heroin or black tar or what they called China much, if at all, anymore. There are traces of it, but they're rare. At this point, that doesn't mean it can't change.
Thank you. I bet other people had that question. I did as well. We have time for another couple of questions. Hey, Melissa.
I think this is for Dr. Hales. I saw that you had a breakdown of the ethnicities, but I didn't see a breakdown in male versus female. I don't know if he's here. Oh,
So you don't currently have that for the, oh, thank you. Okay, so the report that you saw is what's put out by NC Injury and Violence Prevention. Across North Carolina, they give reports by county, and they only report on ethnicity and age. However, we can request that data so that we can see what the rates are by gender. From the national statistics, persons that identify as male are unfortunately experiencing opioid overdose deaths at a much higher rate than other identifications.
okay. Thank you. I have one more question. And Megan knows this is my passion because we're mutual friends and we have sons that are in college. And maybe this is a question for Dina. When the funds get allocated, are they going to be like specifically to certain populations? So we're hearing a lot about street drugs and things like that, and maybe more I can never say that word, indigenous population. But what about the university kids? Because that's where my personal passion comes in. What about the university kids who are literally dying left and right?
So we're going to focus on the high impact strategies, which we had up on the board, and that's what this forum is about, is to hear from everybody here about where the areas are that we need to focus. And if there's a need for us to focus at the university level, then we're certainly in a position to do that.
Okay, good. Thanks.
We have time for one more question. All right, this last question before we break for lunch.
Dr. Hale, I'm trying to think the right word for it. What's the diagram? Sorry. Your diagram on the second to last slide that had all of the intersections on it, I mostly found confusing, but I felt like there was something that I should take away from it. Can you give us any nuggets from that slide?
Yes.
Remember, we've got like 1 minute.
Yeah. You've got a nugget too. Yeah, so basically there are a lot of like what we call risk chains, to where we're trying to understand the series and sequence of events that lead somebody to like their first recreational use to being in treatment. And a lot of these pathways are very helpful in identifying the different stages and levels of intervention, kind of like the mediating mechanisms through which the initial recreational use occurs, and then like full-on opioid use disorder. So really these pathways are nice to identify different mechanisms along that trajectory to where intervention can occur. So these models, they're essentially like systems models, and they have a lot to do with like thermodynamic theory and things like that, which is very complex. I don't understand it, way above my pay grade. But the models themselves are very helpful in predicting essentially those targeted areas for intervention that are critical along the way, not just in terms of prevention, but also intervention. And Lauren has a nugget too to add here.
Because that was one of my favorite slides, because one of the things I didn't get to in the presentation is the emotional component that is very much throughout that slide. So to point to the one slide I had with the vital signs, and when pain became a fifth vital sign, for instance, if you go into a doctor's office and you see a happy face chart that has a bunch of different, emojis, if you will, on it, that's how you're identifying your pain level. Not a blood pressure, it's not measurable, right? And so what people don't really understand across the board on a macro level is that pain has a large emotional component to it. And our bodies store a lot of that, and our DNA specifically, to sort of what that slide, not to sort of, what that slide alludes to is that epidemiology and fourth generation and third generation and secondary generation trauma impacts your coded DNA. So way back in the day, right, I was just a bad person because I picked up a substance, but science shows and indicates that we are at a disposition because of a slew of generations prior to us that were dealing with substance use and mental health and other chronic illnesses. So how you are traumatized 30 years prior to having a kid, if you will, can have an impact on that child.
Thank you, Lauren. Okay, I'm sure there's other questions, but we really need to get moving here. So it's time to break for lunch. We are taking 20 minutes, which allows the two lines to go and grab a box, use the restroom, water up, and come back to your tables. You will not need to be writing anything, and I'll tell you the role of the table host when we return. So thank you, and we'll see you back here in 20 minutes. And so now your work begins. We're going to have 2 breakout sessions, and the instructions are virtually the same, except with the exception of the strategies that you are going to be discussing. So I've got a lot of information to share with you up front of how this is going to run. So I apologize, I'm going to have to refer to my notes to make sure I don't leave anything out. Firstly, you have table hosts at your table, and their role is to take notes on your discussion. I'll explain a little bit more about that in a minute. And to keep the discussion going, and to be the table Nazis if anyone gets really verbose, which I can tend to do. And so what I've told them, and they don't mean to be rude, but if someone's going on and on for a couple of minutes, they're just going to hold their hand up, which means wrap it up. The reason is we've got, how many, 120 people in here. We want to hear from everyone. And so that's why we only have 30 minutes for it. Well, it's going to be 25 by the time I'm finished talking. So we want to make sure that it's moving along. Your table hosts will introduce themselves. They'll share with you their role with Mecklenburg County, and in one sentence, why they volunteer. They're volunteering their time to come and act as a table host. So name, role, why they are here. Then they're going to ask you to introduce yourself, and again, it's very brief, 20 seconds or less. So once everyone has introduced themselves, then we're going to ask you, you've got the materials on your table regarding the 11 strategies. For the first breakout session, we want you to look at the first 2 categories, prevention and treatment. And you are individually going to select which of those 5 you think is the most important, where you think the county needs to focus those funding dollars on. And if you have 1 or 2 sentences on why, that's fine. Again, we're trying to limit each person to a couple of minutes. The table hosts will be taking notes. Some of them have their laptops. The purpose of the note-taking is to provide data that's going to be combined with a post-event survey and other information, maybe the information that our presenters also shared, to be presented to the Board of County Commissioners when it's time for them to make their funding decisions. So while they're taking notes, they're going to be very brief. If they use names on the form, those are going to be deleted. Your names are going to be anonymous. They're not going to be shared. It's simply the purposes of capturing what your discussion was, especially with regard to the strategies. Everyone following me? Okay. At the conclusion of the breakout session, I'll give you a 10-minute warning, then 5-minute warning. I'm going to ask the table host, your tables, you're going to pick a spokesperson. We are not going to have time for every single table in here to report out, but we hope that we can get to at least 2 or 3 tables. So you're going to pick a spokesperson who is going to share with the larger group your table's most important discussion points, what really stood out, were there really a couple of huge commonalities, but they are representing your table, not their own personal beliefs. All right. So, the first breakout session, we are focusing on these 5 strategies that pertain to prevention and treatment. And your table host, will lead you through this. And I believe, the other thing I want to point out is everyone sitting at the table is a participant regardless of their role or title. So if we have some officials in here, take off that official hat. You are now a participant. You're a community member. Okay? Michael. Teasing. And with that, we are going to start the clock. I have 12:40. Begin your discussion. After everyone goes through and names their strategy, that's when you can delve in to have more dialogue that's more organic and ask questions and clarify. So hopefully you'll get through your identified priorities within 10 minutes, and then you can begin a group discussion. So, go. Okay, folks. It's time to come back to the center of the room, to the front. And if I have to, I'll hold my hand up, and when you see my hand, you raise your hand, and when you see people's hands raised, then that means to be quiet. Some people are not playing right. Hands raised. Oh, see, it works. They do. They do this in elementary school, and there's a reason, right? All right, so I've walked around. I've heard some really good discussions, just bits and pieces of it, and we've got 10 minutes for some of the tables to report out. I'm hoping that you did pick a spokesperson who is eager and excited to share what they will about their table's discussion. And so with that, I will, look at all of this. Again, as many as we can get in. So if you go longer than 2 or 3 minutes, hand up. That's what I'm going to do. Got it? All right, this table volunteered first, and I'm going to ask that you stand. How about that?
How about that?
We voted. And remember, I will hold my hand up on you too.
Oh, don't worry. I'm not long-winded. Okay, so this table talked mostly about treatment, and y'all correct me if I'm wrong. We talked a lot about treatment, and how important treatment is, and how it intertwines with so many, with everything, really, particularly the incarcerated. We really talked about that right there at the end, and how important that is to target the incarcerated and get help for the incarcerated. We talked about youth prevention, young adult prescription programs, impact on the bottom line, medical impact treatment, strategic focus. We talked about the inability to eradicate addiction. You're not going to eradicate addiction. And so we specifically talked about, and we like the syringe service programs. And that also would intertwine with treatment. We talked about avoidance of punishment, making addiction a crime, and basically decriminalizing drugs and getting help, particularly with incarcerated people, getting them help when they're incarcerated, but when they come out, how important it is to keep that going and keep them healthy. Mental health, of course, comparatively, you took great notes. Primary interest in treatment, non-clinical, outpatient treatment, all these interwoven efforts that overlap each other. Each level is inclusive of prevention. Treatment focus onto grassroots efforts, stigma in seeking devices, meeting where they are. We talked about that for quite a while, meeting where they are, and in particularly the syringe program. Life-changing circumstances to target the transition of these individuals, focus on the release. Other notes, we talked about abstinence programs are powerful, but lack of multi-level approach. Intergroup stigma with medication use in abstinence-based curriculum, social connectivity, how important that is. The medical component to opioid use, necessity of next steps in the care model similar to existing roles. So that's kind of where we are.
You did. Nicely done. And give her a hand. Thank you. So I'm sure that they echo a lot of the other discussion. And what I did not tell you before is we purposely assigned you to tables so that we get a diverse group of thought, because we have a lot of people from the same organization. We have some partners here, and we wanted you to sit differently to get a different perspective. So what I heard from some of the tables, there were some strong opposing opinions or not in full agreement, which is what we wanted. So if you're experiencing that or some commonality, that's to be expected. And I believe this table was going to go next. Remember, 2 minutes. You've got a cheerleader over there.
Okay, we are table 14, and we were split pretty much 50-50 between early intervention and evidence-based addiction treatment. We acknowledge that both of them go hand in hand, and we have to do both in order to properly address the problem. Specifically for early intervention, we wanted to focus on education that is deep and wide and helps us to battle stigma, eradicate stigma, and help people to recognize the signs of early substance use. Then for evidence-based addiction treatment, we wanted to focus on medication, and increasing quality access to care for people who do not have insurance in Mecklenburg County. We wanted to make sure that we highlight psychiatric care, and then we wanted to highlight the fact that when it comes to outpatient treatment, that it really should be prolonged over a lifetime, and that support for sober treatment communities that expand through patients' life is very important. End of 3 minutes.
Thank you, Kelsey. Okay, we have time for one more, and no, I better go to this side of the table. I'm sorry. I have a feeling they feel neglected over here. But as I said, we sat you with different people, and while we don't have enough time to really get to know each other, of course we encourage you to share phone numbers, emails, so that you can stay in contact. All right.
Right here?
We got one right here.
Oh.
Up. If you can do it in 2 minutes or less, we'll do both of these.
Yep.
Hi, my name is Taylor with Table 2. So kind of in agreement with what a lot of the other tables said, it was really hard for us to just pick one, a top one or a top two. So we kind of lumped them all together. We had the most discussion surrounding evidence-based addiction treatment and treatment for incarcerated individuals and kind of the gap in care for those individuals. And so also going into medication-assisted treatment for incarcerated persons and looking at funding for individuals to do that, as well as the funding for them to continue that and receive the treatment once they are released. There's a gap in coverage there, as well as for kind of going into housing for homeless individuals and incarcerated persons upon release, and then how the syringe service program would be effective, having more of those, in addition to the naloxone distribution, being there's only one syringe service program in Mecklenburg County, which again links to treatment if that's the goal, to get them into treatment. So as last one is early intervention services, kind of focusing on intervention services such as Recovery High Schools, Emerald School of Excellence in Charlotte, and kind of intervening before maybe some opioid use disorders turn into severe opioid use disorders, kind of catching it on the mild or moderate end and intervening then with recovery services.
And we have Frank here.
Yes, we do. Representing Table 4. So I think initially we were kind of leaning more towards naloxone distribution, but as was pointed out to me by my new friend here, that syringe service program includes naloxone distribution. I think that it's, that life-saving effort is essential. We also talked about treatment. I work in addiction treatment, and so I'm incredibly biased towards that. I think that evidence-based treatment we need to broaden our viewpoint on what that means, okay? It is not one size fits all. It cannot be one size fits all, and it has to be adjusted to individual needs. The thing that I'm referencing right now in my head is addressing the chronic pain need. Just because I'm getting off of opiates, the chronic pain is still going to exist. I'm going to need to broaden my approach, understand that I'm not going to be completely pain-free for the rest of my life, but come up with viable alternatives to manage that pain while they're in treatment and then practice them after they leave. However, I also worked in the criminal justice system 100 years ago. I'm pretty biased about that. We were talking about the necessity for prescribing and administering MAT while incarcerated, and then following that up, it's almost a foregone conclusion that the first thing most people who are dependent upon opiates will do after they complete their incarceration is go use the opiate that put them in that place to begin with. I understand that it's going to take a state policy change in order to even be prescribed MAT in the jails. So that's a two-part process there, okay?
Some more good information, different perspectives. For the tables that we did not get to, you're going to have your chance with the next breakout session. And you know what? I'll stand back here unless I have to be up here, because the people in the front are having to turn around and look, so now the people in the back have to turn around and look. Same instructions, but this time if you'll put the recovery slide up, you're going to focus on those 6 strategies that pertain to recovery. And like I said, it's the same format. Table hosts, don't worry about taking too many notes. We just want to capture the high points and people's first priority with regard to strategies. All right, so I will give you a 10-minute warning and then a 5-minute warning, and you are good to go. Okay, let's come back. Let's come back. There you go, hands up. Everyone, hands up. Hands on your head. Hands on your shoulders. Y'all do anything, don't you? Okay, so you had, again, some really good discussions as I was walking around with regard to the strategies associated with recovery. And so we've got 10 minutes to hear from 2 or 3, 4 tables. And look, someone's already jumping the gun there. They want to make sure they're heard. We need to hear from the middle as well. So if you can, just keep it to a couple of minutes or less. And again, you're representing your table's discussion.
Good afternoon. I am with Table 6. We had passionate consensus that we really have to have a shift in how we approach responding to people who are dealing with addiction and recovery. That we have to shift from this sort of compliance-based approach that we have to normalize the behavior. And as we looked at the different recovery strategies, we really saw housing as the #1 priority through which all strategies flow. That, you know, and I see it both as a judge, both on the family court side and the criminal court side, but also as the sister of someone who struggles with addiction and is currently homeless in Arizona. And what we see is when people are struggling with mental illness and substance use disorders and they don't have a safe place to go, they cannot connect with any other resource or service, period. And they just continue to cycle through our different institutions. And the housing has to be unconditional or at least limited conditional housing. I can come as I am. You don't tell me what I need and where I start. I tell you what I need today and where I start. And if I want to leave tomorrow, that's cool too.
Nicely done. You can hear the passion. Okay. Got the table back here. But we're going to come back in the middle. So somebody be ready.
We concurred with Judge Trosh. The housing, when we started looking at each one of these areas, you can't really separate them all. They all kind of come back down to the basic that folks need a safe place to live and they need a good job so that they can support themselves and their families. And everything after that just kind of can fall into place. But without those two, it's just a constant struggle to get through day to day. And I can't think of a greater relapse trigger than being stressed about where am I going to sleep and how am I going to pay my bills and how am I going to eat.
Thank you, Mackie. Okay, I'm coming back to the middle of the room. Justin, they made you, didn't they? They sure did. Okay. This is the rebel table here, because they have a table host reporting.
Hey everyone. So our table, recovery housing stood out as a priority for our group. Community support elements may not be there, and that seems to be a gap across the board. We also need more long-term treatment options. It was mentioned that we have very few treatment center programs that last 6 months or longer, and having more long-term sober treatment living centers would be a resource. Under the post-overdose priority, there was a good bit of conversation regarding combining naloxone distribution with treatment options immediately. So you may save a life in that moment, but how can you intervene then and there and get that individual to a treatment center or program quickly to prevent them from overdosing again? Under employment services, the opportunity for education is missed here. Coming out of jail, you're thinking, what am I going to do to have a home, provide for my family? If we can give them the skills and access to employment and wages despite a prior conviction, this gives them a viable future. In that same vein, educate employers to be second chance employers and provide them with resources so they are equipped to handle the challenges of taking these individuals on as employees. And finally, another thought was the need for better mapping of services within the community. Each agency may have their own go-to list, but having a more comprehensive list to include like grassroots organizations or neighborhood-based organizations would be extremely helpful.
Well, these report outs are going fairly quickly, so we have time for a couple of more. What's a table that have we heard from y'all yet? We have not. Okay, we'll come back to y'all. My goodness, they have some real feelings about this.
So our group talked a lot about serving vulnerable populations, whether that's immediately after an overdose or coming out of incarceration or homeless population. We really like the idea of a post-overdose response or community paramedicine team that could deliver services wherever the individual is at, whether that's harm reduction, naloxone, Suboxone, all, and then be able to go revisit them while you're trying to wrap services around and support them. We also talked about reentry programs and how vulnerable it is coming out of incarceration and needing to have access to both medications, but also have access to housing and reentry into the community. So really just a target on those vulnerable groups.
Thank you. Now, was there another table that wanted to report out? Okay, we do have time for two more, so it's this one and then this one. And sorry for those of you we did not have time for, but we will capture your notes. Okay, who is the bossy one here?
Hold on one second.
Oh, God. We talked about the bossy one made us, table 15. We did say post-overdose response team as well and linking everything together because it's hard to pick just one resource. Everything is linked together. You can't just say, hey, give one funding and not the other. It's kind of everything is linked together as a whole. But one big thing we talked about that is not up there was training. Training overall for everyone in those programs that is overseeing the programs to ensure they know how to put those services out there. Yes.
Thank you. Okay, last table.
We're table 8. We talked, like so many of you, we talked about the housing as a piece. If you don't have anywhere to lay your head, then everything else kind of crumbles. But we also had conversation about everything as well, mainly where the foundation or what foundation helped to, I guess, form whatever the addiction is of the individual as well. What happened, that what we call ACEs, and that's the adverse childhood experiences that the individual had, which caused them to deal with the drugs initially. And so working with that, leading them into the criminal justice system, being able to have a team there, a post-overdose team if it's there, that when they're incarcerated or beforehand. But the other thing is we talked about is, like somebody said, is the training. And so people need to have a passion for this type of work. And we don't have enough people with the right passion, unfortunately. And how do we get those people in or on board? And since somebody else said something about the education piece as well, and because of the student loans and those things, a lot of people kind of refrain from getting into this field. So that was a major issue as well. But the recovery, also we talked about the RPM organization that we have within Mecklenburg, and how those support services can help an individual. One of our teammates as well works at the men's shelter and see a lot of people who just get discouraged because there are not enough companies that will give individuals a second chance based on their record. So we talked about some other programs that would help, and the fact that grassroots organizations really need funding who are actually doing the work to help those in this area.
Thank you, Camille. How many of you were able to garner information that you did not have prior to this event? How many of you have been impacted by someone else's story? So as you can see, this is very worthwhile, and there will be more. But before we close, I'm going to ask Dina to come back out and say a few more words, and then I've got to give you a couple of housekeeping pieces of information before you leave, so stay put. Be a minute or less. Do you want to use this? Yeah.
Okay. Okay, so first of all, thank you. This was an extraordinary day. I learned a lot, and it's obvious that there's a tremendous amount of passion for this work, and I look forward to working with all of you as we put together this plan and really do everything that we can to combat and eliminate opioid abuse in our community. So thank you for that. So today was our first community stakeholder conversation. We will be doing this every year for 18 years because that's how long the money will be available to us. Now, I don't know if it'll be me here for 18 years, but somebody will be doing this every year for the next 18 years. Megan's going to talk to you about the survey, so I'm going to skip that. One of the other things I'm going to do is I'm going to ask the Board of County Commissioners to hold a public hearing at one of their upcoming board meetings so that we can get additional input from the community that we're not able to be here today. We want to make sure that we get as much input as possible. We will then put together our funding plan, our funding strategy, and then we will give that to the Board of County Commissioners for their approval, and then we will able to move forward and start dispersing these dollars. So this was incredibly valuable. I think the input that you've given us is really going to help us a lot as we put together our plan. So thank you so much. It was really great to see everybody today. And with that, I'll turn it back to Megan.
One thing that I failed to mention are our table hosts who volunteer their time to come and take notes. And so let's give them a hand. Y'all wave. They did an awesome job, and we certainly appreciate their interest in this effort. So a couple of housekeeping things. On your tables, you'll see this the QR code, right? If you know how to use this, which I struggle with, this will link you to the post-event survey, but we will also be emailing you that link. It's very, very important that you complete that survey. This is where you as an individual will have a chance to rank your top 5 priorities out of all 11. So that's another way for your voice to be heard. Okay? So you can sit here. The actual survey is going live at 2:05. It's live right now. So before you leave, take care of it. And again, we're going to compile the results of the survey along with these comments, the table discussion, and there'll certainly be more information and data that's going to be used for the funding opportunities. Keep an eye out next year for another chance to come and be heard and get involved.
Sorry. In oversharing, there are 2 QR codes on your table, and you guys are super, super smart. Who knew? The big one is the one that has the survey for today. The smaller QR code on the magnets are for you to take home and will direct you to mecnc.gov. Apologies for any confusion. The survey is on the large QR code, and we hope you do it before you leave today, but if you don't, it will be in your email inbox from me and Eventbrite. Sorry.
Which also reminds me, the mecnc.gov, there's going to be a landing page for the opioid crisis and opportunities and what you were here for today. So keep an eye out for that. It's going to be updated as more information is coming in. And then lastly, your boxes, your box lunch. We asked, this would be hugely helpful if you take those boxes, your trash, and put them either on that table back there, or there's a table where the lunches were set out. That's going to help save probably 30 minutes of cleanup. So just take your trash. If it fits in the trash can, that's fine, but you can certainly just lay it on the tables. And with that, oh, one more thing.
Sorry, again, you guys are super smart. The question came up about, can you share the survey with your colleagues or with advocates? You actually cannot. This survey is for those of you who participated in this experience. That's part of the model of this day. So this survey is for all of you who are in this room. There will be other surveys in the future. As Dina mentioned, there are going to be other public participation opportunities, but that survey that's coming via QR code or email is for you who participated today. Sorry.
Okay, is that it? All right. Anybody else? Thank you again for coming out and sharing your stories and your interest and your wisdom, and we hope to see you when the next opportunity comes up. Be safe.